Welcome to this YouTube channel. I'm glad you are there. Kindly subscribe to this channel. The topic is neurovascular structures of the pelvis. Neurovascular structures of the pelvis. This is part 2. So we are taking a look at the pelvic arteries and the pelvic veins in this lecture. So right away, I'm going to start with the pelvic arteries. Right here is an illustration of the pelvic arteries. Branches, here you have branches of the common iliac artery and branches of the internal iliac artery that supplies the pelvis. So I'm going to talk about these branches shortly. So the pelvis is richly supplied with arteries. Among these arteries, you have multiple anastomoses occurring, and this gives an extensive collateral circulation. So you must not forget the origin, the cause, the distribution, and the anastomosis of the arteries that you find in both the greater and lesser pelvis. So I'm going to explain all that. You have 6 main arteries that enter the lesser pelvis in females. Then in males, you have 4 arteries that enter the lesser pelvis in the males. The internal iliac arteries, you have the branches of internal iliac arteries in females. Then you also have the ovarian arteries in females as paired arteries. So the ovarian arteries in females are paired. Then the arteries that are branches of internal iliac arteries, they also supply the females. So you have 6 arteries in all supplying blood, arterial blood, to the pelvis in females. I'm going to explain that shortly. Then in males, you have just 4. So the males, you have the ovarian arteries as paired arteries, and the ovarian arteries you find only in the females. Then you have the medial sacral and superior rectal arteries as unpaired arteries. The medial sacral and the superior rectal arteries are unpaired. When you say they are paired, like the ovarian arteries are paired, that means you have on the right and you have on the left. But the medial sacral and the superior rectal are unpaired arteries, so you have just 1 each in the body. Right here is an illustration of the details of all the branches of the internal iliac artery and the common iliac artery that supply the pelvis. You also have branches of the abdominal aorta supplying the pelvis. Taking a close look at this illustration, you have branches of the internal iliac artery that supplies the pelvis. So the pelvic arteries that come from the internal iliac artery, they are all illustrated in this diagram. You also have the diagram here showing each internal iliac artery. You can appreciate the internal iliac artery and the branches of the internal iliac artery that supply the pelvis. So each internal iliac artery is approximately 4 cm long, and it begins as the common iliac artery. So it continues from the common iliac artery. The common iliac artery actually bifurcates into the internal and external iliac arteries at the level of the intervertebral disc between the 5th lumbar vertebra and the 1st sacral vertebrae. Between the 5th lumbar and the 1st sacral vertebrae. Note that the ureter crosses the common iliac artery. It either crosses the common iliac artery or its terminal branches, and it does so at or immediately distal to the bifurcation. So you find the ureter crossing the common iliac artery, or you find it just crossing at about the bifurcation, or crossing where you have the terminal branches. The internal iliac artery is separated from the sacroiliac joints by the internal iliac vein and the lumbosacral trunk. The internal iliac artery descends posteromedial into the lesser pelvis, and it goes medial to the external iliac vein and the obturator nerve, and it goes lateral to the peritoneum. The internal iliac artery is the principal artery of the pelvis, as it supplies most of the blood to the pelvic viscera and some to the musculoskeletal part of the pelvis. You need to know that the internal iliac artery also supplies branches to the gluteal region and the medial regions of the thigh, and as well as the perineum. So the internal iliac artery is actually giving off branches that supply so many regions. You have variations. Variations could occur, but the internal iliac artery usually ends at the superior edge of the greater sciatic foramen by dividing into anterior and posterior divisions. That these divisions are actually the trunks because they are large vessels. The branches of the anterior division of the internal iliac artery are mainly visceral. That is, they supply viscera, that's organs such as the bladder, rectum, and the reproductive organs. But these branches also include parietal branches. Branches of the anterior division of the internal iliac artery are mainly visceral, supplying the organs. In addition to these visceral branches, you also have the parietal branches that pass to the buttock and thigh. The arrangement of the visceral branches of the internal iliac artery is actually variable, that is not constant. You have some arteries that commonly arise as branches of the anterior division of the internal iliac artery. These branches include the following arteries that I'm going to talk about. You have the umbilical artery. So before birth, the umbilical arteries are the main continuation of the internal iliac arteries. They pass along the lateral pelvic wall and then ascend the anterior abdominal wall. They go through the umbilical ring to the umbilical cord, and at this stage you find out that the umbilical arteries conduct oxygen and nutrients. The blood they conduct actually is deficient in oxygen and nutrients, and this blood goes to the placenta for replenishment, that's to get some nourishment, oxygen and nutrients. When the umbilical cord is cut, the distal parts of these vessels no longer function and become occluded distal to branches that pass to the bladder. The occluded parts form fibrous cords called the medial umbilical ligaments or cords of the umbilical arteries. The ligaments raise folds of peritoneum, what we call the medial umbilical folds, on the deep surface of the anterior division, anterior abdominal wall. So what happens postnatally? Postnatally, you find out that the patent part of the umbilical artery runs anterior-inferiorly between the urinary bladder and the lateral wall of the pelvis. And as it does so, it gives off the superior vesical artery or arteries that supply numerous branches that go to the fundus of the urinary bladder. In males, the artery to the ductus deferens usually arises as a branch of the superior vesical artery. So the arteries I'm talking about the arteries of the pelvis, the branches of internal iliac artery. I've mentioned the umbilical artery. So we must not forget all the branches that come from the internal iliac artery. Next, I need to talk about the obturator artery. The origin of the obturator artery is actually variable, but usually it arises close to the origin of umbilical artery, where it is crossed by the ureter. The obturator artery runs anterior-inferiorly on the obturator fascia on the lateral wall of the pelvis, and it passes between the obturator nerve and vein. The obturator artery then leaves the pelvis through the obturator canal and supplies the muscles of the medial part of the thigh. You must know that within the pelvis, the obturator artery gives off muscular branches. These muscular branches include it gives us some muscular branches that supply the muscles. It also gives off a nutrient artery to the ilium, and it gives off a pubic branch. The pubic branch arises just before the obturator artery leaves the pelvis. The obturator artery ascends on the pelvic surface of the pubis to anastomose with its fellow of the opposite side, and the pubic branch of the inferior epigastric artery, which is a branch of the external iliac artery. So this is a form of anastomosis. The obturator artery is anastomosing with the one opposite and also with the pubic branch of the inferior epigastric artery, and the inferior epigastric artery is a branch of the external iliac artery. So this is a form of anastomosis between the internal and external iliac artery. You have a common variation in about 20% of persons where you have an aberrant or accessory obturator artery. This one arises from the inferior epigastric artery. So instead of coming from the internal iliac artery, in about 20% of persons, you see the obturator artery coming from the inferior epigastric artery, and it descends into the pelvis along the usual route of the pubic branch. The surgeons, they always note that when performing hernia repairs, they keep this common variation in mind of the obturator artery, so that they will try to be mindful of it and avoid it, so that you don't end up cutting it, and if not, your patient will not be happy at the end of the day, as he will bleed unnecessarily. The extrapelvic distribution of the obturator artery is actually not our business here, because it goes to the lower limb. I'm still looking at the branches of the internal iliac artery. Next, I want to talk about the inferior vesical artery. The inferior vesical artery occurs only in males, and it's what replaces the vaginal artery in females. So while we have vaginal artery in the females, in the males what we have is the inferior vesical artery. The inferior vesical artery passes to the fundus of the urinary bladder. There it supplies the seminal glands, prostate, fundus of the bladder, and the inferior part of the ureter. The branches to the ductus deferens and the prostate are the artery to the ductus deferens. So the artery to the ductus deferens, which is a branch from the inferior vesical artery, supplies the prostate and the ductus deferens, and the prostatic artery supplies the prostate. Then the artery to the ductus deferens supplies the ductus deferens. Both branches come from the inferior vesical artery. The artery to the ductus deferens may arise from the superior vesical artery. So instead of arising from the inferior vesical artery, there are instances where it arises from the what? Superior vesical artery. Next, I must talk about the middle rectal artery. Still talking about the branches of the internal iliac artery that supply the pelvic region. I want to talk about the middle rectal artery. The middle rectal artery may arise independently from the internal iliac artery. So in some cases you find the middle rectal artery coming from the internal iliac artery. In some other cases you find it arising in common with the inferior vesical artery or the internal pudendal artery. So the middle rectal artery at times arises on its own from the internal iliac artery, or at times arises in common with the inferior vesical artery or the internal pudendal artery. The middle rectal artery supplies the inferior part of the rectum, and it anastomoses with the superior and inferior rectal arteries, and it supplies this artery supply the seminal gland and prostate. You have the vaginal artery. We are still looking at the arteries, the pelvic arteries, which are branches of from the internal iliac artery. I want to talk about the vaginal artery. The vaginal artery is it's like what we call the inferior vesical artery in the males. I said that earlier on. So in females we have vaginal artery, while in males we have inferior vesical arteries. The vaginal artery runs anteriorly and then passes along the side of the vagina. Here it supplies numerous branches to the anterior and posterior surfaces of the vagina. It also supplies the posterior inferior parts of the urinary bladder and the pelvic parts of the urethra. The vaginal artery anastomoses with the vaginal branch of the uterine artery. Next, I really need to talk about the uterine artery, still a branch of the internal iliac artery. The uterine artery arises separately and directly from the internal iliac artery, but in some instances you may see it arising from the umbilical artery. It's what we call it's actually the homology of the artery to the ductus deferens. So while you have the artery to the ductus deferens in the male, what you have in the female is the uterine artery. The uterine artery descends on the lateral wall of the pelvis anterior to the internal iliac artery, and it enters the roof of the broad ligaments. So at this point, the uterine artery passes medially to reach the lateral margin of the uterus, immediately superior to the lateral part of the fornix of the vagina. So the uterine artery it passes medially in the broad ligament, and as it passes medially in the broad ligament, the uterine artery passes directly superior to the ureter, near the lateral part of the fornix of the vagina. And this relationship, there is a way this relationship is described. When you have the uterine artery passing superior to the ureter, near the lateral part of the fornix of the vagina. Uterine artery passing superior to the ureter. This relationship of the ureter to the uterine artery is often described as the water, that's urine now, being referred to as water, passing under the bridge, which is the uterine artery. So when you say water passes, of course we know water is under the bridge. So and the water here now is the urine that you find in the ureter, which is inferior to the uterine artery. The uterine artery is superior and it's seen as a bridge over the water. So it helps you to remember that the uterine artery is what? Superior to the ureter. So the ureter contains the urine, which is water. So it's beneath the uterine artery, which is seen as a bridge. So the uterine artery goes on as it reaches the side of the cervix. The uterine artery divides into a smaller descending vaginal branch. This small descending vaginal branch supplies the cervix and vagina. Then it also gives a larger ascending branch. The larger ascending branch runs along the lateral margin of the uterus, and this branch supplies the body and the fundus of the uterus. The ascending branch bifurcates into the ovarian and the tubal branches. So you have the ovarian and tubal branches of the uterine artery coming up from the ascending branch, bifurcation. These continue within the broad ligament to supply the medial ends of the ovary and the uterine tube. And then you have anastomoses with the ovarian and tubal branches of the ovarian artery. Permit me to talk about iatrogenic injury of the ureters during ligation of uterine artery. I said a while ago that the uterine artery is lies superior to the ureter, and the fact that the ureter passes immediately inferior to the uterine artery near the lateral part of the fornix of the vagina is important to us clinically. The ureter is exposed to danger of being clamped or crushed, ligated or transected during hysterectomy, that is excision of the uterus. So when you're doing a surgery, hysterectomy, that's to remove the uterus, the ureter is exposed to the danger of being what? Clamped or crushed. And this can occur when the uterine artery is ligated and severed to remove the uterus. Because when you remove the uterus, you have to ligate the uterine artery so that the patient does not bleed to death. So when you ligate the uterine artery, because the ureter is just inferior, you need to really be careful so that you don't crush or damage the ureter, clamp it in the process. So the point at which the uterine artery and ureter cross lie approximately 2 cm superior to the ischial spine. Now, let me talk about the internal pudendal artery. The internal pudendal artery is larger in males than in females. The internal pudendal artery passes inferiorlaterally anterior to the piriformis muscle and also anterior to the sacral plexus. The internal pudendal artery leaves the pelvis between the piriformis and the coccygeus muscles, and it does so by passing through the inferior part of the greater sciatic foramen. The internal pudendal artery then passes around the posterior aspect of the ischial spine or the sacrospinous ligament, and thereafter enters the ischioanal fossa through the lesser sciatic foramen. The internal pudendal artery, along with the internal pudendal veins and branches of the pudendal nerve, pass through the pudendal canal in the lateral wall of the ischioanal fossa, and as it exits the pudendal canal medial to the ischial tuberosity, the internal pudendal artery divides into its terminal branches, and these terminal branches are the deep and dorsal arteries of the penis or clitoris. So it gives the terminal branches you have are the deep and then the dorsal arteries of the penis in males and then of the clitoris in females. Let me talk about the inferior gluteal artery. The inferior gluteal artery passes posteriorly between the sacral nerves, that's usually the second and the third sacral nerves, and it leaves the pelvis through the inferior part of the greater sciatic foramen, inferior to the piriformis muscle. The inferior gluteal artery supplies muscles and skin of the buttock and the posterior surface of the thigh. So it doesn't actually supply the pelvis, but it goes through the pelvis. So that is why we call it it's one of the pelvic arteries, though it's not innervating, it's not supplying any structure in the pelvis. Now let's see the posterior division of the internal iliac arteries. All these branches I've mentioned so far are actually branches of the anterior division of the internal iliac artery. When you take a close look at the diagrams I showed you earlier on, you will see that the internal iliac artery divides to give you an anterior division and a posterior division. So the anterior division is where, from the anterior division, you have all the arteries I've been talking about for the past few minutes. Now from the posterior division, you also have some arteries, and the following arteries there are three arteries that come from the posterior division of the internal iliac artery. The three arteries that come from the posterior division are the superior gluteal artery, the iliolumbar artery, and the lateral sacral arteries. So those are the three arteries that come from the what? Posterior division of the internal iliac artery. So the superior gluteal artery, this artery passes posteriorly, and it runs between the lumbosacral trunk and the anterior ramus of the first sacral spinal nerve, what we call the S1 nerve. The superior gluteal artery leaves the pelvis. It leaves the pelvis through the superior part of the greater sciatic foramen, and at this point is superior to the piriformis muscle, and the superior gluteal artery supplies the gluteal muscles in the buttock. So it's not actually supplying the pelvic structures, but it's giving off there. So it's part of the, we refer to it as part of the pelvic arteries. So you note that some of these pelvic arteries don't actually supply pelvic structures, but they are giving off in the pelvic region, so we say they are pelvic arteries. Next artery that you have from the posterior division of the internal iliac artery is the iliolumbar artery. The iliolumbar artery runs superiorlaterally in a recurrent manner. That's, it turns sharply backwards. When an artery or nerve turns sharply backward, we say it's recurrent. So the iliolumbar artery runs in a recurrent manner, turning sharply backwards relative to the source, that it's coming out from the posterior division of the internal iliac artery. As it arises, it will now turn sharply backward, and it will now go to the iliac fossa. So the iliolumbar artery, within the iliac fossa, what happens to it? The iliolumbar artery divides into an iliac branch, which supplies the iliacus muscle and the ilium, and it also gives a lumbar branch. And what happens to the lumbar branch? It supplies the psoas major and the quadratus lumborum muscles. Last but not the least is the lateral sacral arteries. That's of the three branches of the posterior division of the internal iliac artery. So the lateral sacral artery is the last of the three arteries you have coming from the posterior division of the internal iliac artery. What about the lateral sacral arteries? The lateral sacral arteries usually made up of superior and inferior arteries on each side. So on each side you have the lateral sacral arteries, some inferior and what? Superior on each side. And the lateral sacral arteries may actually come from the common iliac artery. So instead of coming from the posterior division of the internal iliac artery, the lateral sacral artery might come from where? The common iliac artery. The lateral sacral arteries pass medially and descend anterior to the sacral anterior rami. That's the anterior rami of the sacral spinal nerves. And the lateral sacral arteries give off spinal branches which pass through the anterior sacral foramina and supply the spinal meninges, which enclose the roots of the sacral nerves. Some branches from the lateral sacral arteries pass from the sacral canal through the posterior sacral foramina and supply the erector spinae muscles of the back and skin, which overlies the sacrum. So you have some branches from the lateral sacral arteries passing from the sacral canal through the posterior sacral foramina, and these branches supply the erector spinae muscles of the back. These branches also supply the skin that overlies the sacrum. What happens when there is ligation of internal iliac artery? What happens? Does collateral circulation occur in the pelvis in such a situation? You must know that there are times that occasionally the internal iliac artery is ligated to control pelvic bleeding. If, for example, there is an accident, the pelvic structures are damaged, lacerated, and then you find out that the patient is bleeding, there's severe bleeding from the pelvic region. What happens? You might need to ligate the internal iliac artery to control the pelvic hemorrhage. You must know that because of the numerous anastomoses between the arteries branches and the adjacent arteries, ligation usually will not stop blood flow, but it only reduces the blood pressure. So what happens? It will, when you ligate like that, it will help to contribute to the arrest of bleeding, that's hemostasis. So it will help control of the bleeding and encourage blood clotting so that the patient does not bleed to death. So you have collateral pathways to the internal iliac artery, including from anastomosis. Some arteries anastomosing. You have lumbar and iliolumbar arteries. Anastomosis between lumbar and iliolumbar arteries is one of the collateral circulation you have. So even when you ligate one of the vessels, one of these two vessels, you still have blood coming from the other one. You also have anastomosis between the median sacral and lateral sacral arteries. You also have anastomosis between superior rectal and the middle rectal artery. You must remember the anastomosis between the inferior gluteal and the deep artery of the thigh. So blood flow in the artery is maintained even if you have ligation. The blood flow is also maintained, though it may be reversed in the anastomotic branch. So even you ligate a branch of the internal iliac artery, you might have blood flowing from some other collateral branch, and the bleeding will still be there, but the blood will be, hemostasis will be encouraged so that blood clotting, bleeding can be arrested. The collateral pathways may maintain the blood supply to the pelvic viscera, the gluteal region, and the genital organs, even when there is ligation of any particular branch, pelvic artery, any of the branches of internal iliac artery. Now let me talk about the ovarian artery. The ovarian artery actually arises from the abdominal aorta. Ovarian artery, one of the pelvic arteries, the arteries you find in the pelvis, arises from the abdominal aorta, inferior to the renal artery. But at times you could find it superior to the inferior mesenteric artery. So you find the ovarian artery arising from the abdominal aorta, inferior to the renal artery, but superior to the inferior mesenteric artery. The ovarian artery goes inferiorly, and as it passes inferiorly, the ovarian artery adheres to the parietal peritoneum and runs anterior to the ureter on the posterior abdominal wall. Usually, as it does so, it gives branches to the posterior abdominal wall. Then the ovarian artery enters the lesser pelvis. As it enters the lesser pelvis, it crosses the origin of the external iliac blood vessels, that's the external iliac artery and vein. The ovarian artery then runs medially in the suspensory ligament of the ovary and enters the superolateral part of the broad ligament. There it divides into ovarian branch and a tubal branch, which supplies the ovary and the uterine tubes respectively. These branches anastomose with the corresponding branches of the uterine artery. A word about iatrogenic injury of the ureters during ligation of the ovarian arteries. So the ureters are vulnerable to injury when the ovarian blood vessels are ligated during an ovarectomy. That's when you are doing excision of the ovary. You are removing the ovary. Maybe the ovary there's a tumor. It could be a cancer or any other tumor of the ovary. When you are in such a case, you might need to remove the ovary. So when you're removing it, you need to ligate the ovarian artery and vein so that the patient does not bleed to death. So in such a case, in such a situation, the ureters are vulnerable to injury because they are nearby and they are close to the ovary. So as the ovarian artery crosses the pelvic brain, it's close to the ureter. So when you are doing ovarectomy and you ligating the ovarian artery, for example, the ureter, which is quite close, could be damaged. You really need to be mindful of the ureter so that you don't damage the ureter and create more problems for the patient. Now let me talk about the medial sacral artery. The medial sacral artery is a small unpaired artery that usually arises from the posterior surface of the abdominal aorta. A while ago, I talked about the ovarian artery coming from the abdominal aorta. Then now I'm talking about the medial sacral artery, which also coming from the abdominal aorta. So the medial sacral artery is unpaired, it's small, and it comes from the posterior surface of the abdominal aorta, just superior to its bifurcation. That's superior to the bifurcation of the abdominal aorta. Just before it bifurcates, it gives off the medial sacral artery. Before the medial sacral artery enters the lesser pelvis, there are times it gives rise to a pair of arteries, what some call the L5 arteries. It's a pair. So as the medial sacral artery descends over the sacrum, the medial sacral artery gives off some small parietal, what we call the lateral sacral branches, that anastomose with the lateral sacral arteries. It also gives rise to small visceral branches, and these small visceral branches go to supply the posterior part of the rectum, and these branches anastomose with the superior and middle rectal arteries. The medial sacral artery actually represents the caudal end of the embryonic dorsal aorta, and this caudal end is actually reduced in size because you have the tail-like caudal eminence of the embryo disappearing. So you find this caudal end reduced in size. So the caudal end of the embryonic dorsal artery is reduced in size. The superior rectal artery is the next artery I want to talk about. The superior rectal artery is a direct continuation of the inferior mesenteric artery. The superior rectal artery crosses the left common iliac artery and vein and descends in the sigmoid mesocolon to the lesser pelvis. At the level of the S3 vertebra, that's the third sacral vertebra, the superior rectal artery divides into two branches, and these branches descend on each side of the rectum and supply it as far as these branches go out to supply as far inferiorly as the internal anal sphincter. The superior rectal artery anastomoses with branches of the middle rectal artery, and the middle rectal artery is a branch of the internal iliac artery. So the superior rectal artery also anastomoses with the inferior rectal artery, a branch of the internal pudendal artery. So much for the pelvic arteries. I really need to go on to talk about the pelvic veins now. So the pelvic veins are illustrated right here. The pelvic veins empty into they are tributaries of the internal iliac vein and the common iliac vein. So they all empty into the internal iliac vein, and eventually the blood gets to the common iliac veins. So all the pelvic veins are illustrated here. You can see the obturator veins, the superior vesical vein, inferior vesical vein, and the inferior apogastric vein. So the pelvic plexus, venous plexus are illustrated right here. The superior gluteal vein is there. Don't forget to take a look to see that, identify that. Even the iliolumbar vein is there. So uterine vein is there. So you find out that the pelvic, all these arteries I've been talking about, you have the corresponding veins, all tributaries of the internal iliac vein, and the blood will eventually get to the common iliac vein. So the pelvic venous plexuses are formed by the interjoining veins, and these veins surround the pelvic viscera. These communicating network of veins are very important to us clinically. You have various plexuses, venous plexuses within the lesser pelvis. You have some network of veins around the rectum forming the rectal plexus. You also have around the bladder forming the vesical plexus. You also have the prostatic plexus, uterine plexus, and the vaginal plexus. So all these plexuses within the lesser pelvis unite, and they drain mainly by the internal iliac veins, like I said before. But some of them drain through the superior rectal vein into the inferior mesenteric vein. So most of these pelvic venous plexuses then drain directly into the internal iliac vein. But you're going to find some of them draining what? Through the superior rectal vein into the inferior mesenteric vein. Some also drain through the lateral sacral veins into the internal vertebral venous plexus. In addition, the parts of venous drainage from the lesser pelvis also includes parietal median sacral vein, the superior rectal vein, which goes to the portal system, and then in the females, very importantly, you have the ovarian veins. We must not forget that the internal iliac veins merge with the external iliac veins to form the common iliac veins, which unite at the level of the vertebra L4 or L5, that's the fourth lumbar vertebra or fifth lumbar vertebra, to form the inferior vena cava. The internal iliac veins lie posterior inferior to the internal iliac arteries. The tributaries of the internal iliac veins are similar to the branches of the internal iliac arteries, which I mentioned earlier on, except that there are no veins accompanying the umbilical arteries between the pelvis and the umbilicus. The iliolumbar veins from the iliac fossa of the greater pelvis usually drain into the common iliac veins. Then you have the superior gluteal veins, the accompanying veins, which we call the vena comitans of the superior gluteal arteries of the gluteal region. So the vena comitans of any artery is the accompanying veins. So the superior gluteal veins actually accompany the superior gluteal arteries. So we call them the vena comitans of the gluteal arteries. And you find them draining the gluteal region. And the superior gluteal veins are the largest tributaries of the internal iliac veins. Except during pregnancy. What happens in pregnancy? In pregnancy, the uterine veins become larger than the superior gluteal veins because of the demands of the pregnancy. The uterine veins have to be larger. They have to get larger during pregnancy, so they become larger than the superior gluteal veins. You have testicular veins which traverse the greater pelvis as the testicular veins pass from the deep inguinal ring towards the posterior abdominal. So you must note that the superior gluteal veins, the accompanying veins, that's the vena comitans of the superior gluteal arteries, are the largest tributaries of the internal iliac veins, except during pregnancy, when the uterine veins become larger. Then testicular veins traverse the greater pelvis as they pass from the deep inguinal ring toward their posterior abdominal terminations. But these testicular veins do not drain pelvic structures. Why I'm mentioning the testicular veins here is that they pass through the greater pelvis. Right here is an illustration of all the pelvic veins. The pelvic veins, the tributaries of the internal iliac veins, the pelvic veins which are tributaries of internal iliac veins are illustrated right here.